Dear friends, colleagues, we are going through difficult times of this pandemic, and as medical professional, we have to take extra care to be safe, protected, cover your face, use N95, do hand hygiene, use a face shield. I am Dr. Ajay Handa. I have worked in the Armed Forces Medical Services, that is Army, Navy, Air Force put together for 30 years. I'm a trained pulmonologist and an internal medicine specialist. I have 22 years of experience of internal medicine, and I'm a professor of internal medicine in various universities and the national board. So today we have chosen the topic of approach to diffuse lung diseases and what's the role of the pulmonologist. And I would like to talk about this to you all and take this vast topic and give you a brief overview over the next 20-25 minutes, and then I shall take your questions at the end. If there are any questions, please go to the questions tab in your laptop or your hand phone and type it, and I'll try to answer your questions in the end. So going off to the topic proper, diffuse lung diseases and the role of the pulmonologist. So this is a brief look at the pulmonary lobule. The secondary pulmonary lobule is a part of the lung which is distal to the terminal bronchiole and has respiratory bronchioles and alveolar sacs, as you can see towards the left end of your slide. And the alveoli are all of them are closely related to the blood vessels, that is the pulmonary artery bringing in the blood, which is blue in color, and then pulmonary capillaries which are formed, and then along the periphery you can see a pulmonary vein taking away the oxygenated blood, and in the border is also a pulmonary lymphatic vessel. So in the border of this interlobular septae, this polyhedral structure, this polygonal structure is called a secondary pulmonary lobule. If you take a section of the alveoli, you look at the right hand side, you find the alveoli are essentially thin walled epithelial lines, air sacs which contain air that we inhale, and closely related to that is the capillary, the pulmonary capillary, and the alveolo-capillary membrane is the gas exchanging membrane of our body. And the space in between the alveoli and the endothelial cell is essentially the interstitium. So essentially it's a very, very thin area which is having a few cells, a little bit of type 4 collagen, and nothing much other, and few fibroblasts. So diffuse lung diseases are those diseases which involve the lung parenchyma in a diffuse manner, that is, involve all the regions of the lung. They are clubbed together because they have a common clinical presentation. They usually present with progressive dyspnea and dry cough as a combination of them. They can be acute, subacute, and chronic in onset, and we will look at that separately. But they usually have these two progressive prominent symptoms, that is progressive dyspnea and dry cough. And as the alveolo-capillary membrane is affected and becomes thicker, it impacts the diffusion of oxygen into the capillaries, and hence hypoxemia is a early and a prominent manifestation of this disease. Usually the patient will have an X-ray with bilateral infiltrates. Rarely it would be only on a CT scan that the physician thinks that there is a diffuse lung disease and an X-ray has not picked it up. This situation happens in about 10% of cases where the X-ray could be normal. Early diagnosis is very important because if you pick up an inflammatory condition affecting the lungs, you could prevent ongoing damage to the lungs, because as I mentioned, hypoxemia, that is respiratory failure, can compromise the person's existence. So if it is a severe hypoxemia, you could halt that, and earlier the intervention in inflammatory condition, the better the response to treatment. And if it is an infection related diffuse lung disease, as we shall see, then it could prove to be life-saving. This is an example where the chest X-ray could have very, very minimal or subtle abnormalities on the left-hand side in a case of miliary tuberculosis. And we have seen patients with normal X-rays, but the suspicion is high. It's a pyrexia of unknown origin. When you do a CT scan, and you find these randomly distributed nodules which are suggestive of miliary tuberculosis. Look at the pathology. On the left-hand side is the normal lung parenchyma with thin in alveolo-capillary membrane having no infiltration. It's a thin structure through which gas exchange happens. Normally, diffusion is not compromised. And on the right-hand side, if you see the interstitial spaces, the alveolar septae are widened and they have inflammatory cells in them. This is a diffuse lung disease called non-specific interstitial pneumonitis, and acronym is NSIP, which we shall be using. So this obviously would be associated with symptoms of progressive dyspnea, dry cough with or without hypoxemia because of the compromise in the gas exchange alveolo-capillary membrane being affected. So why are they called diffuse lung diseases? We all prominently know them as interstitial lung diseases all these years. In fact, this term interstitial lung disease is still widely used in most guidelines. But lately, the authors feel that the term diffuse parenchymal lung disease or diffuse lung disease is a better terminology, because though they begin in the interstitium, they can progress to go and involve the other structures in the pulmonary lobule, which I showed you, namely the alveolar spaces, the terminal bronchiole, both the pulmonary artery and the pulmonary vein, and the lymphatics. Hence, it is not limited to the interstitium. Hence, the term diffuse lung disease is a better terminology, many feel. Coming to the etiology, this condition can be caused by over 200 etiologies, which can cause interstitial lung disease. And of course, there are other conditions where there can be infiltrates in the lung, are the other conditions where you could have in special circumstances. Let us consider those, and then we will come to inflammatory conditions first. So on the right hand side, if the person is immunocompromised, say for example, he has got an HIV infection, it could be miliary tuberculosis, it could be a renal transplant patient with pneumocystis infection, or a patient with a bone marrow transplantation who is neutropenic could have aspergillosis. You could also see patients on various transplant recipients, like kidney and liver transplant recipients, having infections like CMV, EBV, and influenza. Not to forget, the commonest diffuse lung disease in the present scenario is actually caused by coronavirus, with COVID-19 causing diffuse ground glass opacities in the CT scan as a characteristic manifestation. If it is related to a person who is residing in the coastal areas and has got eosinophilia, it could be a diffuse lung disease caused by microfile area, where it's called tropical pulmonary eosinophilia. If a person has got classical history of paroxysmal nocturnal dyspnea and underlying cardiac dysfunction with or without diabetes, hypertension, you could be dealing with a diffuse lung disease, diffuse infiltrates due to pulmonary edema. And similarly, a patient who has renal failure could be landing up with pulmonary edema or fluid overload due to renal failure. Coming to the classical inflammatory DLDs, the commonest ones being idiopathic pulmonary fibrosis, connective tissue disease related lung disease, hypersensitivity pneumonitis, sarcoidosis, pneumoconiosis, alveolar hemorrhage syndromes due to systemic vasculitis, and drug toxicity. And we'll talk about most of them in today's presentation briefly. Very important to identify what is the time course of the illness, whether the illness has set in a few hours or days, in which case you're dealing with the acute DLD. Acute DLDs can be caused by a variety of conditions, but to name a few, it could be related to connective tissue diseases. For example, systemic lupus erythematosus or polymyositis dermatomyositis. It could be acute hypersensitivity pneumonitis, a large amount of exposure in a farming activity to thermophilic actinomycetes, or a large amount of exposure to bird droppings can cause acute hypersensitivity pneumonitis. And the last AIP is acute interstitial pneumonia, which was called as Hamann-Rich syndrome. It is the acute interstitial pneumonia where the person develops ARDS-like picture in a very short period of time due to interstitial inflammation involving the entire lung. And it's a condition which is very highly fatal. The other conditions which we discussed just now could be cardiac failure, infections, and fluid overload. All of them will also present acutely, so one cannot neglect them in the appropriate clinical scenario. If the presentation is of a few days to weeks of cough and breathlessness associated with or without clues to connective tissue disease. It could be connective tissue diseases like SLE or rheumatoid arthritis, or a subacute hypersensitivity pneumonitis. The term idiopathic non-specific interstitial pneumonia, this condition also figures in a subacute manner. Chronic DLDs are those conditions which present with a history of more than 6 months to a year. So if a patient is elderly and has cough, breathlessness over more than 6 months to a year duration, idiopathic pulmonary fibrosis would figure very high in the differential diagnosis. Connective tissue diseases like rheumatoid and scleroderma involve the lung in a very slow manner and can present with chronic diffuse lung disease. Similarly, exposure in farming activities over years can cause chronic hypersensitivity pneumonitis. So it's important that we take the clues from the history of the patient, what kind of exposures has been there, especially if there is a clue that the person has got occupational exposure to farming, poultry activities, or is a bird breeder, he's been exposed to silica or other mining activities, stone crushing activities, road construction, etc., or he's got exposure to asbestos like ship boiling, tiles, roofing, etc. If there are individuals who have got an underlying heart disease, do always check their prescription if they have been taking amiodarone for chronic atrial fibrillation, or he's received bleomycin for testicular carcinoma, or for treatment of lymphoma. If there is a very clear-cut history of rheumatoid arthritis or systemic sclerosis, it could be a connective tissue disease-related lung disease. Now, physical examination gives you a few clues. That is, idiopathic pulmonary fibrosis can be associated with clubbing. It's a prominent sign. Presence of cyanosis indicates that it is severe and is causing respiratory failure, usually more important in patients who present acutely, because this patient would need a triage to go into intensive care unit. Bilateral Velcro crackles like the Velcro strap would be very characteristically heard in idiopathic pulmonary fibrosis and also in chronic conditions such as rheumatoid-related lung disease. Signs of pulmonary hypertension are very, again, indicative of chronic hypoxemia seen in idiopathic pulmonary fibrosis. If the person has certain skin lesions, which I shall show you, or he's got red eyes, you could be dealing with sarcoidosis or connective tissue disease. Now, we talked about immune compromised status like HIV or renal transplant. This is a CT scan of a patient which shows pneumocystis infection. The patients who were subjected to this study, almost a 12-year period in Switzerland, it was found that a simple test like bronchoalveolar lavage was able to confirm the diagnosis of bacterial infection or aspergillus or CMV or pneumocystis. Since the study was done in Switzerland, the incidence of tuberculosis on the lower side. Similar studies from India have shown the prevalence of tuberculosis, pneumocystis infections, and bacterial infections to be higher, followed by fungal infections, followed by CMV. So now talking about the few common conditions which are encountered, CTD associated diffuse lung disease encounters about 30% of the practice of a pulmonary specialist. Once the CTD is accompanied by lung involvement, the disease mortality increases. The later you detect, the more difficult it is to reverse, so reversibility is lost. It should be suspected in young individuals who are having a CT scan which shows NSIP, because CTDs mostly cause non-specific interstitial pneumonia type of infiltration. When you have a clue like a malar rash or pitting scars on the digits or presence of facial telangiectasias, or the right hand side lower image which shows perioral salt and pepper distribution with a reduced oral aperture, or the left hand side hand image which shows the presence of the blanching indicative of the phenomenon where there is vasospasm, Raynaud's phenomenon. These all indicate the presence of underlying SLE or systemic sclerosis. A simple test like anti-nuclear antibody by immunofluorescence, and if the titer is high, you could do in a blot to see which type of antibody. For SLE, it would be a double-stranded DNA. For systemic sclerosis, it would be anti-SCL70. Rheumatoid factor and anti-CCP if you're suspecting rheumatoid arthritis-related lung disease. Coming to sarcoidosis. Sarcoidosis is a multi-system granulomatous disease of unknown etiology. It involves the lungs in over 90% of cases, lungs meaning intrathoracic lymphadenopathy and lung parenchyma together. eye involvement as depicted in the picture of anterior uveitis, and skin involvement like erythema nodosum are common presenting symptoms. It may be picked up incidentally when an X-ray is done for a routine medical examination for joining an occupation, or routine medical examination for going abroad, which shows bilateral hilar adenopathy. And this is how the X-ray would look, with large potato-sized nodes on both the hilar regions, and with or without on the right-hand side showing presence of reticular shadows and nodular infiltrates in the lung parenchyma, classical in the mid and perihilar region, suggestive of sarcoidosis. A CT scan, a contrast CT scan, would show these enlarged lymph nodes in the right and left hilar region, paratracheal region, and the subcarinal region. And this is a tool which a pulmonologist can use. Endobronchial ultrasound, called as EBUS for short, and the lymph node is visualized under real time, and the needle, as you can see in the top right hand corner, the needle is entering the lymph node, and you're doing a biopsy under real time. And this is avoiding the major vessels which are close to this region, the pulmonary artery, the aorta, and the other branches of the pulmonary vessels. To diagnose sarcoidosis, one modality is to use the ABUS, but if there are infiltrates in the lung parenchyma, you could do a transbronchial lung biopsy by passing the bronchoscope and the biopsy forceps in the lung parenchyma till it meets resistance, and you could take small pieces of lung biopsy from here or from the bronchi which have infiltrates, nodularity, or maybe even appearing normal. You could pick up non-caseating granuloma. In such circumstances with abnormal lungs, you could pick it up to the tune of almost 90%. An important and an old test called MAN2 is very helpful in sarcoidosis, because over 95% of patients have tuberculin energy. That means their test will be negative. If there is a tuberculin reactivity more than 10 millimeters, we must rule out the presence of active tuberculosis by doing culture for Mycobacterium tuberculosis, gene expert, and a smear for tuberculosis, and a biopsy, of course. Hypersensitivity pneumonitis is the next entity. It is prevalent to the tune of 20%, and the Indian registry said that the prevalence of hypersensitivity pneumonitis in northern India is to the tune of 40%, possibly because of exposure to dusts and organic contents of the air coolers, which are more often used in the northern regions of the country. So they are commonly due to farming activities, exposure to birds like pigeons, indoor birds, people keep fancy birds inside, or poultry workers who work with poultry and turkey, etc. And in jobs where they are exposed to dust like wheat, that is atta chakki workers, rubber industry, and antibiotic industry. And this is a limited list. The list is very long. So if a person has got hypersensitivity pneumonitis, you have to look at the book and look at what are the agents which can cause, and take a meticulous history for that. Imaging is very characteristic. Imaging will show these areas of dark, which are shown with the black arrow, which are areas of air trapping because of bronchiolar involvement. And there are areas of white, which are ground glass opacities. So this combination of white and dark infiltrates are suggestive of something which is called as a mosaic attenuation pattern. It's like the mosaic tiles which we used to have in our homes, alternate black and gray and lighter shades. So that's why the mosaic pattern, also called as a cheese head pattern. And on the other side, if you see, you can see faint centrilobular nodules in the lungs. These are all the bronchioles which are having their secretions, and this could be a characteristic imaging feature. In fact, the radiology colleagues give us a great help in identifying hypersensitivity pneumonitis. Workup exposure history is absolutely crucial. BAL will show lymphocytes more than 20%, and a lung biopsy, if done in such a circumstance, could show loosely formed granulomas with interstitial inflammation. Avoidance is crucial, so exposure history is very important. Now coming to the idiopathic interstitial lung diseases, idiopathic pulmonary fibrosis is the commonest, happens to be in elderly males. Smoking is strongly associated, and look at the progression of the disease. This has a 5-year mortality of 90%, almost 75 to 90%. This has reduced a bit with the availability of important molecules like pirfenidone and nintedanib, but the cost of nintedanib is a major concern for using it widely. But the mortality has been improved by the use of these agents by adding almost 3 years to a life of a patient of idiopathic pulmonary fibrosis. X-ray could show these kind of reticular shadows or honeycomb as the red arrows show, but look at the CT scan, how well it is delineating the honeycomb. To show the honeycomb, I have also put shape of the honeycomb of a bee's honeycomb, which it creates meticulously. That's how the lower lung fields appear. This on the left hand side is early honeycombing, on the right hand side is well established honeycombing. The condition radiologically is called as usual interstitial pneumonia, or UIP for short. This is characterized by subpleural lung involvement of the lower lobes more than the upper lobes, and the presence of honeycombing with traction bronchiectasis. If you look at this bronchus, it is looking as a dilated bronchus from center to periphery. Normally it's supposed to taper. This is central. This is traction bronchiectasis. It is dilated because of the fibrosis. And the last line, which is most important, absence of atypical features. These are atypical features which, if present, you cannot make the diagnosis of UIP. So if these 3 are present and the 4th is absent, you can call it definite UIP, and a biopsy is not required. You can just make a diagnosis of UIP on the history and clinical findings. But the atypical findings which need to be ruled out are ground glass opacities, nodules like the CT scan shows here, presence of mosaic attenuation as I showed you in the hypersensitivity pneumonitis, and presence of cystic lung disease, which is seen in the CT scan here, where there are cysts. Cysts are dark colored spaces in the lung. This is cystic ILD, which can be seen in a few specific types of rare ILDs like LIP and LAM. All UIPs are not IPF. So if you have a bird breeder or a farmer who has got UIP, or if you have got a rheumatoid arthritis patient who has got UIP, or an asbestos patient who has got UIP, or amiodarone or bleomycin history in the past, this is likely to be UIP due to these conditions and not IPF, because IPF, once you label the patient IPF, it is associated with a very high mortality. These other forms of UIP don't have that severe and that sinister a connotation or progression. Coming to the next entity, idiopathic non-specific interstitial pneumonia. Idiopathic, I will tell you, because it has to be diagnosed after ruling out certain conditions. It is earlier stages, it is cellular, and later on it becomes fibrotic. This is one of those conditions which responds well to steroids, and look at the survival, 5-year survival, almost 75%. So these patients do very well as against IPF, who do very poorly. On the left hand side is cellular type of NSIP, which shows ground glass opacities, and on the right hand side you can see the fibrotic type of NSIP, where there is some traction bronchiectasis and presence of a minimal amount of honeycombing. Minimal honeycombing is not that much of an issue. If you have gross amount of honeycombing, that is a feature of UIP. So minimal honeycombing can be seen here, and this is fibrotic, this is cellular. The left hand side is cellular, earlier stage. So to make a diagnosis of idiopathic NSIP, if there is history of connective tissue disease, or if the serological markers of ANA and other markers are positive, one cannot make the diagnosis. So diagnosis of idiopathic NSIP is excluding connective tissue disease, excluding hypersensitivity, excluding sarcoidosis, and excluding the exposure to certain drugs, which we shall see. The third common type of idiopathic interstitial pneumonia or idiopathic interstitial lung disease, or DPLD, is cryptogenic organizing pneumonia. It is called cryptogenic because it has to be diagnosed after ruling out the other conditions which I mentioned in the lower part of the slide, that is infection, connective tissue disease, and drugs, just like idiopathic NSIP. So it's very common to find post-viral organizing pneumonia or post-mycoplasma organizing pneumonia, post-pneumocystis organizing pneumonia, Sjogren's syndrome with organizing pneumonia, rheumatoid with organizing pneumonia, and certain drugs with organizing pneumonia. That is not cryptogenic. Cryptogenic is when nothing of these is found, then possibly it is cryptogenic. But again, gratifying is that cryptogenic organizing pneumonia is another entity where there is a good response to corticosteroids. HRCT in cryptogenic organizing pneumonia shows patchy consolidation in both the lungs. You can see it is patchy, and it is usually subpleural, and distributed in more than one lobe. Here you find this characteristic sign which is called as a reverse halo sign. That is a round area of infiltration with a central area of clearing. Reverse halo sign is also quite characteristic. Now, if there's history of exposure to silica like a miner or asbestos like a shipbuilder, then this could be suggestive of silicosis, where there are lots of nodules. And if you look at the mediastinal lymph nodes, you could find eggshell calcification. Here, if you look at the other side, you find so much of honeycombing, but it is only on one side and less on the other side. And there is this area of pleural fibrosis, which if you look at the mediastinal window, you could even see pleural plaques and calcification. This is asbestos related diffuse lung disease with honeycombing. Drugs, list of drugs is mentioned here. It's important for every patient to ask if he is taking the list of the common drugs which are known to cause. So it's important to make a list and note it down. Nitrofurantoin, patients take it for a urinary tract infection prophylaxis, usually causes acute to subacute diffuse lung disease. Methotrexate, again acute, subacute and chronic. Amiodarone, usually acute and chronic. Bleomycin, both acute and chronic. Other types of drugs in specific circumstances like dasatinib can also cause pleural effusion with interstitial involvement. So this is the limited list, but we had a patient who had gallbladder cancer, and this patient was referred for dry cough, progressive breathlessness. In the setting of chemotherapeutic drugs, you have to make a diagnosis of drug-induced lung disease after ruling out infection. So we took him up, we did the bronchoscopy, we ruled out infection like tuberculosis, fungal infections, and bacterial infections, and the biopsy showed organizing pneumonia. The drug was stopped and he was given corticosteroids with a good clinical response. Now, what is the role of the pulmonologist? All this while we've been talking about how to take the history, how to examine, and how to do the workup. So it can be done by everybody, but just we focus back again on the common types of diffuse lung diseases in India. The common types of diffuse lung diseases from this study in North India from Patel Chest Institute were sarcoidosis, idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, connective tissue disease, and hypersensitivity pneumonitis. This figure can be more in certain places and less in certain places, but by and large, idiopathic pulmonary fibrosis, sarcoidosis, CTD associated diffuse lung disease, hypersensitivity pneumonitis will be the ones which you will be commonly encountering. This is one of our patients who presented with alveolar hemorrhage. We were able to diagnose this based on the presence of this uniformly hemorrhagic ball. He was an elderly person who presented with fever, cough, and hemoptysis. The working referral diagnosis was tuberculosis. We also found that he had presence of raised creatinine and an active urinary sediment. So our working diagnosis was possibly vaginous granulomatosis with diffuse alveolar hemorrhage, and by doing this bronchoscopy, the diagnosis was confirmed that it is an alveolar hemorrhage. Subsequently, his C ANCA came positive and he was treated for systemic vasculitis. So bronchoscopy has an important role apart from the BAL, which we mentioned in doing and ruling out infection, BAL for confirming the diagnosis of diffuse alveolar hemorrhage. We can take bits of lung biopsy, as I mentioned in sarcoidosis, to confirm the diagnosis. Now, this is a case where miliary tuberculosis was found on biopsy. The BAL was negative for AFB, but on the biopsy, we found these areas of caseating granulomas in the patient. On the image here, you can see caseating granulomas, multinucleated giant cell, and epithelioid cells. Now, in a sarcoidosis patient who has a similar kind of imaging, lung biopsy showed non-caseating compact granulomas, and this was with this we were able to diagnose sarcoidosis. This tool, that is bronchoscopic lung biopsy, has a good yield in certain conditions where the involvement of the disease is close to the bronchioles. So sarcoidosis, hypersensitivity pneumonitis, organizing pneumonia, and other infections like tuberculosis, which are more diffuse in nature, this has got a good yield. Also in eosinophilic lung disease, it has a good yield, but it is not so good because the pieces are only about 1 to 2 millimeters or 2.5 millimeters in size in conditions where UIP or fibrotic NSIP is suspected, or in fact, for that matter, chronic fibrotic hypersensitivity pneumonitis, because the small size is inadequate for the pathologist to give a clear-cut diagnosis. So new tools, just like Mr. Bachchan evolves in his life to occupy newer roles and perform for us. And God bless him, he's fighting at this moment and on the path to recovery from COVID. This is a new bronchoscopic tool called cryobiopsy, wherein the bronchoscopic forceps is special. It uses liquid nitrogen at -28 degrees. It is passed through endotracheal tube under general anesthesia, and the fluoroscopy guidance is used because we are going to take a bigger piece of lung. After you pass the forceps, you see on the fluoroscopic guidance that the forceps is at least 2.53 centimeters away from the pleura, and then you freeze the lung tissue and take out bigger pieces, and I'll show you how big they come. And obviously the bigger the piece, the greater the chance of bleeding. So to control the bleeding, you put in a Fogarty balloon before to take the cryobiopsy, and the moment the biopsy is taken, the Fogarty balloon is inflated to give balloon tamponade to that region of the lung to prevent excessive bleeding, because bleeding has been noted to be moderate to severe in as many as 5%. So a Fogarty balloon catheter is mandatory. Pneumothorax can happen because if you take a larger piece of tissue, and more if you go to the periphery, in almost 10% of cases. So this is the cryobiopsy forceps. This tip will be inserted inside, and this part will be connected to the region from where the liquid nitrogen will be allowed to be circulated inside to freeze the lung tissue. And this 2 centimeter size of piece is received, which is as good as you can get in a surgical biopsy. And this is diagnostic by picking up. This is characteristically what is shown by the pathologist, that is microscopic honeycombing and fibroblastic foci, an area of complete distortion of the lung architecture, which is characteristic of idiopathic pulmonary fibrosis. And once cryobiopsy is done, you don't need any other thing, but it is not required, as I was telling you, to be done in every patient. It should be done where the suspicion is high and the imaging is not typical, or the individual is relatively young and you're not able to come to a diagnosis based on clinical, radiological, serological testing. So cryobiopsy is good. It is a very fast emerging tool for the diagnosis of diffuse lung disease, but it is a teamwork. It has to be done in centers with high expertise to do a cryobiopsy. So towards the end, I would like to highlight certain take-home points. It's important to go back to our basic history elicitation for diffuse lung disease, because as you can see, it's important to find out whether the individual has got exposure to farming or bird droppings, or he has got exposure to certain drugs to come to a conclusion. Clinical examination like presence of Raynaud's phenomenon, Velcro crepitations, and presence of clubbing are very important. In early conditions, an X-ray will show diffuse infiltration, or maybe normal. If you're suspecting, think of the condition, possibly a high resolution CT scan should be evaluated. If there is an immunocompromised status, infections have to be ruled out because they are potentially treatable and life-saving. An early referral to the pulmonologist is always better for the diagnosis and evaluation, because earlier the diagnosis, earlier the institution of therapy, the better the prognosis and the recovery. And so also for the infection in immunocompromised host, where the response will be gratifying and the patient will walk out with the treatment. High resolution CT scan and bronchoscopy are two important friends of the pulmonologist and helps us arriving at the presumptive diagnosis before we take up the case for the evaluation and confirmation of the diagnosis is made. I would like to pay a tribute here to Professor Shigeto Ikeda, who in 1966 developed the flexible bronchoscope and is regarded as the father of flexible bronchoscopy. And with this, in the last 5 decades, the practice of pulmonology has changed on its head, and thanks to Professor Shigeto Ikeda for that. With that, I come to the end of my formal talk, and I would like to tell you all that please stay safe and well protected. And from here on, I would like to take questions, if any, and thank you for a patient hearing. Jai Hind. So I see a question from Anchal, but Anchal has left. So let's take Soma Sundaram. When will you start? What's the question? Second one. Yeah, okay, so what are the treatment options is the third question. Treatment options, Dr. Somasundaram, would depend upon what is the diagnosis. So let's say I talk about the common conditions. So idiopathic pulmonary fibrosis is one of the commonest interstitial diffuse lung disease that we encounter in clinical practice. So our treatment would be in those who have mild to moderate disease. You can start antifibrotics like pirfenidone early and try to retard the progression of the fibrosis. In those who have moderate to severe disease, you could start again pirfenidone or the more costly agent tyrosine kinase inhibitor like nintedanib. These two agents have been used. They slow down the decline of the forced vital capacity and improve the individual's longevity to some extent. Nintedanib, in addition, has been known to improve the patient's outcome because it definitely decreases the incidence of acute exacerbation of ILD, that is acute worsening of the idiopathic pulmonary fibrosis, and that condition by itself is associated with a mortality of almost 50%. So that depends upon the diagnosis. So one is idiopathic pulmonary fibrosis. Mostly the other conditions would respond to corticosteroids. The duration of treatment would vary from 6 months to 9 months in patients who have idiopathic disease like idiopathic NSIP or idiopathic cryptogenic organizing pneumonia. If a patient has got a connective tissue disease related DPLD, then the treatment would be longer because it's been seen that if you discontinue therapy, the disease will relapse. So they would be on a lower dose steroid therapy with along with the agent, an immunosuppressive agent like mycophenolate or azathioprine or even methotrexate for that matter, with patients of rheumatoid arthritis, and this would be continued for a longer period of time under close clinical monitoring, watching that the adverse effects of the other drugs are there and keeping it on a dose which keeps the lung condition in a stable state and does not allow it to worsen. Sarcoidosis responds beautifully to corticosteroid. Hypersensitivity pneumonitis responds to shorter duration corticosteroids provided there is no ongoing exposure. Some cases of hypersensitivity pneumonitis also benefit from an additional drug. If they are tapering steroid and you find the symptoms coming back, you would like to add a drug like methotrexate. I hope I have answered your question to your satisfaction. So treatment is based on the diagnosis that you make for the diffuse lung disease. Yeah, so the next question is very good from Dr. Mohan Babu. How can we suspect early interstitial lung disease in a poultry worker? So early disease, I would recommend that you do a clinical examination and a exercise desaturation test. If you are able to have a finger pulse oximeter, which now everybody has, please do a 6-minute walk test. If you can do it, you can create a small area in your clinic where the person can walk up and down for you can a distance of a 10-meter can be marked, and he walks from there round and round, and he can take multiple shuttles at his own comfortable pace, and at the end of 6 minutes you will have a 6-minute walk distance, and you will have a pre and post oxygen measurement by oximetry. If there is a more than 4% drop in oxygen saturation, it definitely indicates, as I was telling you, alveolo-capillary membrane is affected in interstitial diffuse lung diseases early, so there will be an involvement of diffusion and he'll have a desaturation. Both the distance and oxygen saturation will be lowered compared to a healthy individual. Obviously, with the activities, if there is exposure and you have clinical signs like crackles and clubbing, he needs further evaluation by an X-ray, CT scan, bronchoscopy. The serological markers are notorious for being falsely elevated in asymptomatic people and negative in symptomatic people. So serological markers for hypersensitivity pneumonitis, both bird related and farmer related and other hypersensitivity pneumonitis related, have not been helpful to us to diagnose. So it's exposure, clinical desaturation, CT scan, and bronchoscopy, and BAL showing lymphocytosis. If your biopsy picks up loosely formed granulomas and it's negative for tuberculosis and the exposure is there, response to treatment. So that's a good question, Dr. Mohan Babu. What are the remedies to be taken for a lung cavity? Okay, so lung cavity is a focal lung disease. It is not really a diffuse lung disease. But since it is a question, we should try to explain that a lung cavity in our country is due to tuberculosis in most circumstances and most patients. So you would like to rule out tuberculosis by taking history or fever, cough more than 2 weeks, weight loss, hemoptysis, and then you would like to do a sputum examination, and confirmation of the diagnosis would be achieved on just simple test of sputum microscopy. If sputum microscopy is negative, you would like to do a sputum CBNAT, and rarely in cases which are still not diagnosed, you would like to do a CT followed by a bronchoscopy to look at what the bronchoalveolar lavage shows. So this is one of the most common conditions of a lung cavity. That is not the only condition. You could also have lung cavities and cavitating tumors. You could have thin-walled cavities or thin-walled lesions coming up in infections like staphylococcal pneumonias where pneumatoceles form. You could have pneumatoceles forming in pneumocystis infection. Post radiation, you could have cavities. You could have cavities in sarcoidosis. And those are all less common. I would like to emphasize rule out tuberculosis in our condition as in our scenario, in our epidemiology as the first cause. So if there are no more questions, thank you for being with me in this webinar on diffuse lung disease, and we look forward to hearing from you. Please refer patients to us for evaluation of diffuse lung disease and other lung diseases. We'll be able to help you and help the patients improve their health and the community health in general. Stay safe, stay well protected. Thank you.